My name is Dr. Joseph Sparano. I am Chief of the Division of Hematology Oncology and Deputy Director of the Tisch Cancer Institute at the Icahn School of Medicine at Mount Sinai. Well, of course, a breast cancer diagnosis can be overwhelming, and it's important to be prepared for your initial visit with questions that you might have before the visit, and recognize that not all of your questions may be addressed at your initial visit, and additional questions may come up in the course of your visit. So it's always important to write down those questions and make sure that your physician adequately addresses them. I would say that the most important things to understand and come away with at your first visit include: what is the stage of the cancer? Is it localized? Is it locally advanced? Or is it more advanced? Is it metastatic and spread to other organs? That's obviously a very important piece of information. The second would be the biology of the cancer. Does it express the estrogen and progesterone receptors, meaning that it could be estrogen dependent and be very responsive to anti-estrogen therapy as a critical component of therapy, whether that be in the early stages or the advanced stages. Another component of the biology is, does it overexpress or express something called HER2 or HER2? If it does, it identifies a cancer that's more aggressive, but whose aggressive properties can be neutralized by therapies that target HER2. And there are a variety of different therapies that can target the HER2 pathway in both early localized stages of breast cancer and more advanced stages of breast cancer. And the third component of the biology is, does the cancer not express either the estrogen and progesterone receptor or HER2? About 15% of all breast cancers fall into this category. These are the most aggressive types of breast cancer that often, almost always require chemotherapy, but for which we have newer therapies that can harness the power of the immune system for treatment. And the type of treatment you will receive will reflect both your stage and the biology of the cancer. And then finally, with regard to the types of treatment, it would be important to know what are the appropriate treatments for a patient with my stage and my biology. For those who have localized disease to the breast, that will require surgery to be curative and may require additional therapy, including radiation therapy to the breast and or chest wall and regional lymph nodes, or it may require, and that's called local therapy. It may also require systemic therapy. That is treatment that can address whatever microscopic remnants of disease there may be in other parts of the body that can't be detected by either blood tests or imaging tests. And those treatments can include endocrine therapy or anti-estrogen therapy, which can be very effective for the 70% of patients whose tumors express the estrogen and or progesterone receptor. It can be anti-HER2 directed therapy, which can be very effective for the 25% or so of patients who have HER2 overexpressing disease. So those are really the critical components of the therapy. It's both the local therapy and the systemic therapies. And the decision about which of those to use or whether they should be used in combination really depends upon your stage at diagnosis and the biology. Well, in order to diagnose a breast cancer, a biopsy must be done. Technically, it's not a surgical procedure that requires general anesthesia. Usually, a breast biopsy to make the initial diagnosis can be done either by fine needle aspiration, but more commonly, a core biopsy that can be done either using sonographic guidance, mammographic guidance, and sometimes guidance by an MRI if it can't be visualized by sonography or mammography. These procedures can usually be done under local anesthesia. Um, for the treatment of a breast cancer, that almost always requires a surgical excision of the primary tumor and oftentimes, the adjacent draining lymph nodes. And that's a potentially curative procedure. Sometimes we may advise non-surgical treatment, and that typically would be for an older woman who may have other, significant medical illnesses that may want to avoid surgery and use medical therapy to control the disease. And again, that would typically be an elderly woman who has substantial medical problems, who may be managed safely with just anti-estrogen therapy. About 20 or so years ago, pretty much every patient with breast cancer, or most patients with cancer, I should say, who presented with either early stage disease, the vast majority were advised to receive chemotherapy after surgery to reduce the risk of having a recurrence in other parts of the body. And the theory was that the administration of this chemotherapy after potentially curative surgery, despite the fact that blood tests were normal and there was no signs on any imaging studies, such as CAT scan, PET scan, bone scan, of any evidence of spread elsewhere, we knew that a substantial proportion of patients can have a recurrence of the cancer years, sometimes many years after their initial diagnosis, 5, 10, 15 years or longer. And we knew from carefully performed prospective clinical trials that if we gave a course of chemotherapy ranging anywhere from 4 to 6 months after surgery, that we can substantially reduce that recurrence risk. But we couldn't identify patients who didn't benefit from therapy. So that put us in a situation where we treated the vast majority of patients in order to reduce the risk of recurrence for the few who might be deriving benefit. Fortunately, within the last several years, new diagnostic tests have been developed that can be done on the tumor tissue that don't require any additional biopsies or any additional procedures. They can be done on the tissue that's already been removed. That can provide clearer guidance regarding whether there's likely to be a benefit from chemotherapy. And the availability of those tests and the evaluation of those tests in carefully conducted prospective clinical trials has shown us that we can identify a large proportion of women, up to 80%, who previously were recommended to receive chemotherapy may no longer require chemotherapy to achieve the same outcome. So this has greatly facilitated the sparing of chemotherapy in patients with early stage disease. In more advanced stage disease, where the cancer may have spread to other organs, we now have very effective therapies, including endocrine therapies, CDK4/6 inhibitors, antibody drug conjugates, immunotherapy, a variety of different treatment approaches that can effectively control the disease for substantial periods of time. And that allow us to either delay the need for chemotherapy or in some cases completely avoid the use of chemotherapy. So I think we're doing a much better job nowadays in sparing the use of chemotherapy. And I think that will continue to, the need for chemotherapy will continue to diminish as we find more effective and less toxic ways to manage the cancer and prevent it from recurring. Breast cancer certainly cured when it presents with localized to the breast and sometimes regional lymph nodes. The problem with the localized early stages of breast cancer is that, as I've said before, there's a risk of recurrence in other parts of the body that can occur years after therapy, despite local therapy. No adjuvant systemic therapies, type of therapies I talked about, endocrine therapy, anti-HER2 therapy, chemotherapy, and now immunotherapy can substantially reduce that risk of recurrence. We're now, rather than looking at 5-year cure rates, we're looking at 10-year and longer cure rates. But we do need to follow women for a very long time, 10, 15, 20 years, in order to monitor them for evidence of recurrence. And I think the future holds promise for tests that will allow us to follow patients in a more refined way to truly identify those individuals who are at the highest risk of recurrence, so that we don't have to follow the majority of women as closely as we do now and be concerned about recurrence. So those tests are now currently being evaluated, and I believe in the next 5 or 10 years they will work their way into routine clinical practice. For triple-negative breast cancer, up until recently, the only chemotherapy option for patients with both localized disease limited to the breast and or regional lymph nodes and metastatic disease involving other organs has been chemotherapy. However, in the last 5 or so years, and especially within the last few months, there have been new treatments that have been FDA approved for the treatment of both localized and metastatic triple-negative breast cancer. That is immunotherapy that unleashes the power of the body's immune system to identify the cancer cells and either control or eradicate the cancer cells. And it's been shown that this immunotherapy drug, which is an intravenous medication which can be added to chemotherapy, can increase the likelihood of responding to the treatment, whether the disease be localized or advanced, and can also reduce the risk of having a recurrence for patients who present with localized disease, or prolong the survival and control of disease for patients who have more advanced disease. So this is a major new advance and leap forward for triple-negative breast cancer. In addition, it's been recently shown that for patients who have tumors that are associated with an inherited predisposition to breast cancer based on a mutation or alteration of certain genes, often called the BRCA1 and 2 genes, which confer an elevated lifetime risk of developing breast cancer and ovarian cancer. We now know that certain orally administered drugs called PARP inhibitors can be very effective in the treatment of patients who have more advanced stages of disease, metastatic disease, but also can reduce the risk of recurrence in patients who have earlier stages of disease, high risk triple-negative breast cancer. And this is especially true for patients who have triple-negative breast cancer, because BRCA1 and BRCA2 mutations tend to be associated with higher rates of triple-negative breast cancer. So this is another important advance in the field. We also have a new class of drugs, antibody-drug conjugates, where a chemotherapy drug is essentially hooked up with an antibody or a protein that can recognize a specific target on the surface of the breast cancer cell in general, and in particular triple-negative breast cancer cells, and be effective in controlling the disease. So this is now another new therapy that's FDA approved for the treatment of more advanced stages of triple-negative breast cancer. So we have many more options today for triple-negative breast cancer than we did a few years ago and even a few months ago. Well, the major message I have for breast cancer patients is hope and options. And the majority of women who present with localized breast cancer are potentially curable with the appropriate therapy. And that often includes a multi-modality approach, including surgery, many cases radiation after surgery to sterilize the breast tissue and regional lymph node tissue of any microscopic cancer cells that might be remaining, and then systemic therapies. That is endocrine therapy, anti-HER2 therapy, immunotherapy, and in some cases chemotherapy to reduce the risk of having a recurrence of the cancer. So I think we do have, I think, great hope for the vast majority of women who present with breast cancer. We have better treatment options. We can cure more patients with less therapy and more precise therapy, and we're better positioned to manage every patient that we see now than we were 5, 10, or 20 years ago. And I have no doubt that the next 5 or 10 years will bring continued improvements that will allow us to cure more patients with less therapy that has less side effects.